Good afternoon, sir. Thank you very much for the very kind introduction, sir. It's always a very humbling experience talking in front of my beloved teachers. My hearty thanks to my good friend, Kumarvel, who we've associated right from my school years, to give this talk today. So, my topic is interesting, this insulin therapy. I mean, a lot of GLP-1ization or GLP-1 GIPization. So, insulin therapy, it's an old drug, new tricks. So these are my conflicts of interest, none for this talk, but I am a KOL for a lot of these insulin companies. So what I thought I'll do is I'll give you a series of cases and try to tell you why this still is relevant in today's age. So insulin's been around for 100 years, but in 2026, we ought to understand that it's become smarter. Like, we have smartphones, insulin's become smarter in a lot of ways. It's more smart in terms of delivery, it's very powerful, and it works in synergism with lots of other molecules. So trick number one, I've kind of put some cartoons to make it interesting. It's a post-lunch session. I was supposed to do another session. Fortunately, I've got this session where I'm with friends and colleagues. So action is a revolution, faster and quicker, longer to linger. So what does that mean? So you're looking at insulins. You have the rapid-acting and the basal insulins. The problem is, when you use rapid-acting insulin, are you controlling the postprandial? And after controlling the postprandial, are you going for postprandial hypoglycemia? So that needs to be corrected, and that's why you need a good, smart, rapid-acting insulin. And if you look at the normal insulin from the pancreas, it's pretty quick. You've got the first phase, and the second phase is pretty quick, and you need to kind of replicate it. So any insulin, which as Sir mentioned, Krishnamurthy Sir mentioned, that you're not going to get that near equal, but you'll get it as close to equal. So you want a drug which has flexibility, if a rapid-acting insulin, something which can be given even with the meal or even after the meal, and something which can basically affect and bring down the postprandial blood glucose appropriately and prevent the tail effect and cause postprandial hypoglycemia later. That's what you need to do. And the basal insulins, you need it to be continuous, consistent, flat, effective. So going from NPH, glargine, degludec, now you have the glargine 300, and then you also have the once weekly insulins which are due to come. So we've come a long way. And then you have the concentrated insulin. So when people require a lot of insulin, it's like your palkova. So you take a small amount, but it's very powerful. So if you're using a lot of insulin, it takes a small space and it's pretty effective. And if you look at the profiles of the insulins which we have and which are evolving, you can see how flatter they've become and how continuous and consistent they've become. So this is important for us to understand. So let's kickstart with a 70-year-old male with 15-year history of diabetes. When someone's 15-year-old, obviously 15 years of diabetes, their control is not going to be great. And this person is on a lot of insulin. As you can see, he's on like greater than 100 units of insulin on metformin. His body mass index is high, so consistent with very high doses of insulin. His initial investigation showed a very poor control. A1C is pretty high, fasting and post-meal pretty high. And this was he's very meticulous. He maintained self-monitoring blood glucose daily for years. And these were his peaks. So now with this, what could you do? So the simple answer is, if you have someone who's having a problem in the prandial and also in the basals, the pre-meal levels, best is to convert them to analogs. And when you convert into analogs, you actually get this better. And this is what we did with this patient. So we actually gave him a shorter, faster, ultra-fast acting, short-acting, and a long-acting. And what you can see is basically the glucose levels actually getting better. So the blood glucose profile improved in 24 weeks, and because of the over-insulinization, the reduction of the dose, the weight came down from 103 to 84. So 19 kilograms of weight loss in a few months. And after 6 months, this was pretty sustained from a HbA1c of close to 10 to 7.2. The second person is actually a 50-year-old who's an anesthetist with type 1 diabetes and is on atropine and insulatard, and the blood glucose basically is 170 and 230, and the HbA1c is 9.7. And going with the previous talk of what Dr. Arun said, I mean, with this, how would you adjust? It's important you understand what's going on. So with this, basically, you need to do a continuous glucose monitoring sensor. And again, you need to change them to, an analog insulin for better improvement. You can see from the continuous glucose monitoring sensor, with the introduction of an analog insulin, both the basal and the short-acting, you can see that the glycemic variability is coming down pretty well, and you can see how flat it comes sequentially. And that's the benefit with these ultra-modern insulins, which actually improve the glycemic variability. And as it says, the long-acting basal insulin analogs like degludec or Toujeo offers 24-hour control, reduces hypoglycemia in comparison with other basal insulins. And the ultra-fast-acting insulins like Fiasp or Lyumjev help control postprandial hypoglycemia appropriately and avoid the post-meal hypoglycemia. And this glycemic variability has important connotations in terms of the complications. Now we've moved to an era of basal insulin going to weekly once. So from a T-half of being like, for 24 to 36 hours, you now have a T-half of like, 1 week. And this is with binding to albumin. Now the binding with albumin actually prolongs this insulin action for a period of 7 days. And the steady state is achieved within a span of 3 to 4 weeks. And by achieving so, you actually get better control. Now who would need this? Not everybody needs this. So this is horses for courses. So you have people who basically would need this in particular situations. Someone who's erratic, someone who's elderly, someone who's dependent on care, someone who cannot up-titrate, someone does not want to look at their blood glucose levels. So that kind of a person, you could offer this. This clearly is not for everyone. Do we have evidence? We do. We have certain studies which looked into this, the Onwards group of studies which actually looked at this. Interestingly, it showed that the HbA1c was comparable with your older type of basal insulins. And the hypoglycemia was near comparable. So in effect, this is pretty equally effective, equally safe, and basically at sometimes maybe even better in terms of efficacy. So that's part number one. The trick number two, interesting with what Trump and Iran is doing, entry through all major routes. The Strait of Hormuz is like insulin. It's not just one route. Air or sea will not matter. You can enter anyway. So you can do this if you appropriately, know what you're doing. And that can be done only by monitoring. And when you say monitoring, we've moved away from self-monitoring, we've gone to continuous glucose monitoring, and now we've gone into different kinds of delivery systems. We've gone from the continuous subcutaneous insulin infusion, the routine, to the hybrid closed-loop pump, or the AID. That is the automatic insulin delivery systems. So this is a 28-year-old who wants to plan pregnancy. She's got 14 years of type 1 diabetes, A1C is 9.4 to 10, and is on older insulins. So as I said from initially, you move this person to analogs. She accepts, basal bolus, she understands dietary concepts, she does self-monitoring of blood glucose, she does everything. So we moved her to faster-acting aspart, and she's on also glargine 300. Now with this, the A1C comes down to 7.4. Now this clearly is not clearly enough to achieve pregnancy. You want this to be tighter. So what could you do? Now, if you look at the CGM stats, you understand why this is just up and down. It's all over the place. So how could you actually control this? And this is where you have the continuous subcutaneous insulin infusion. Now, this has been there for a lot of years, but why is the modern insulin infusion pumps better? So this is the CGMS, which I started on first with basically, the continuous infusion. And as you can see, the glycemic variability is better, but still not perfect. And then you have the closed loop systems of the artificial pancreas, where you have the pump and you also have the sensor, and the sensor basically is augmented, and the pump is augmented by what the sensor is doing. The sensor checks and basically augments what the insulin is doing. So this particular individual was put on this. She was put on an insulin pump with a CGMS, which is augmented. This is the Minimed 780G system, which is very much available in India. This is automated. It's an automated basal, meaning it would check blood glucose and it would automate basal insulin infusions based on what the glucose readings are. And this happens every 5 minutes. Every 5th minute, it basically happens. And this is through the Guardian 4 sensor, which is a very well advanced modern sensor. This basically anticipates, it adjusts, and it corrects blood glucose. So this is how it is. And you can connect it to your phone. So on one side of the abdomen, you have the sensor. On the other side, you have the pump, and then you can connect it with your phone. And the phone basically tells you what glucose is, what's happening. And for this person, this is what we did. We gave her this pump, and as you can see here, you have the pump, and this is her phone. Now, this is the beauty. You can see the blood glucose levels here, this basically here, and these pink levels are basically what the basal infusion is doing. And these ones here are the corrections. So it autocorrects. So what you see here is the glucose goes up, these blue lines, the pump is correcting. So the pump is correcting and it's coming back flatter, 103, 192. And then you have, a meal, you enter how much carbs you're taking, it basically delivers as per the calculation. And you can see here the autocorrection, as I mentioned, the blood glucose is peaking, there's a correction. As it comes down, it stops. There's no pink here. The pink is the continuous basal, so it stops. It autocorrects. And with this autocorrection, basically you get a flatter reading. And this is a dream come true. This is this particular lady who actually went through pregnancy successfully. And you can see her time in range, 100%. And you can see below 70, 0, average 121. This is where technology is taking us. And this is the tricks which we need to learn. So this is someone I put on in 2016. This is someone on a pump. I fondly call this AI1 with my name on it. It's my instructions. And you can see that artificial intelligence with autocorrect. You can see who's better. Hands down, the AI wins. No way I'm going to get to that level. But still, we're near equal. But that's basically what it is. So the practice points I have here is the tricks, the autocorrect and artificial intelligence will find its way increasingly into medicine, from self-monitoring of blood glucose to CGMS. It's important that we incorporate and be aware of the modern technologies that are very vital for all practicing doctors. The AID, or the automated insulin delivery system, is now approved not just for type 1 but for type 2 also. And this is important for us to understand as a good trick. Now, closing the loop with autocorrect and automated insulin delivery is something which we need to understand. The next trick is synergism. Synergism is the key. There's a saying, it says it takes two to tango. It's very important that we actually, group together. Now, why is this so? If you look at, grouping things together, we have the co-formulation where you basically, use a long-acting, 24-acting basal insulin and a prandial insulin. You have basically insulin degludec and the short-acting Fiasp as Ryzodeg. This is different from your normal insulins like your Mixtard or your Novamixes, because basically it has, a short-acting which is ultra-fast and a long-acting which is ultra-long, which gives you the best of both worlds. So a soluble co-formulation of this basically would achieve a good prandial control for that meal and a 24-hour basal control throughout the day. Why is this important? As we mentioned, it will correct the pre-meal and it will also correct the post-meal for that particular meal. And it will prevent the post-prandial hypoglycemia, which will be present in the other mixed insulins called the shoulder effect. So this is just a proof of concept. This is a 70-year-old, an elderly person with 10-year history of diabetes, has got complications, has got neuropathy, is on linagliptin, metformin, dimacron, voglibose, and basically is not under control. So this is an elderly person. She's not very keen on insulin. Now, how can you convince her? You can convince her saying that, you could go on a once daily injection, a co-formulation, her HbA1c is 9. You want it to be under control. You have lots of ways you could treat this. But with the neuropathy, maybe, giving her a once daily insulin is one of the options. So we started her on the co-formulation with 10 units, and then it eventually went down to 6 units, and after 3 months, basically the A1C dropped down to 7 with good improvement of symptoms. So it's just the only co-formulation. You could also co-formulate a GLP-1 analog with basal insulin. Now, why combine these two? Now, with GLP-1, we know, we've spoken a lot about it. You can get HbA1c correction, fasting postprandial, the weight comes down, and you also have some side effects. But with basal insulin, you get all these, but the weight increases. When you combine both, you actually get best of both worlds. You do a combination of a co-formulation with GLP and basal, you get the best. And what do you have here? You have something called FRCs, or fixed ratio combinations, like you have the Mixtards and the mixed insulins, the 25-75 insulin ratios, or the 50-50 ratios. You have a combination of basal insulin and a GLP-1, the iDeglira, the iGla-Lixi, and the iCosema. So you're having best of both worlds. The iDeglira has basically degludec and liraglutide. The iGla-Lixi has glargine and basically lixisenatide. And iCosema has got icodec and semaglutide, which are both once weekly preparations. The others are the once daily preparations. So you can see how much further we're going in terms of therapy. So combining these basically means you're getting best of both, better control, fewer hypoglycemias. So the old approach was, the sugars are bad, you increase insulin, you start with basal, then you go to basal plus, then you go to basal bolus. Now, we don't do that nowadays. Remember, this is type 2. It's not about just fixing insulin. It's about fixing where the problem is. It's the insulin resistance. Obviously, you can go, the first injectable should always be a GLP-1. And then the next injection should be a GLP with basal. So instead of that, you could just go with a fixed ratio combination. Just use a single injection, which is equal to your basal bolus. And before you add insulin, you can just add these, before you add short-acting insulin, you can just add these. This is a very interesting trial, which is called Beyond. And what they did was they used people on 4 times insulin, basal bolus. They stopped it, and they actually gave them either basal insulin with GLP-1s or basal insulin
with SGLT2 inhibitors. And then what you can see here is the A1Cs basically got better. The insulin dosing schedule also got better. So if you actually combine all of this, you use basal GLP-1 with an SGLT2 inhibitor, with metformin, with appropriate diet, you got best of everything. And that's basically what's going to be the future. So if you have this particular individual, just showcasing that. This is a 50-year-old with type 2 diabetes, 10 years duration, is on a lot of oral drugs, is on a lot of insulin. This is what we see day in and day out. 50 units of insulin on all the drugs, and in spite of that, A1C is around 10. What do? There's something wrong. Clearly, yes, the patient's diet, lifestyle is the first thing which always has to be fixed, and that remains the cornerstone, the first, the middle, and the last. However, from therapy point of view, what would you do? This these again is a very meticulous person. These were his readings. As you can see, his blood glucose goes from 44 to 300. So it's so variable. Recurrent hypos followed by hyperglycemia. And he says, I've got everything. I'm doing everything right. So what do? So what did we do? In this kind of a situation, use basically an FRC, which is a fixed ratio combination, which is GLP and basal. So what we did is we used basically a short-acting insulin in the morning, breakfast, and lunch, and we gave him basically, a fixed ratio combination. And what did we do with this? We actually stopped the DPP-4, and what was found was his time in range sequentially, as you can see, has gone phenomenally better from that, 98%. And this is his level of basically glycemia, which is pretty flat compared to what it was happening before. As you can see here, his daily basis control is good. But people are people. If you can look at this closely, look at what he's doing. So 2 idlis, half dosai, 3 idlis with little honey, mani sambar rice. Look at this, 4 buris and 3 small vades. The problem is there. The problem remains there. What are we going to throw at them if you're not going to correct this, and they're not going to correct this, it's not going to go away. But in spite of this, you can see the molecule is actually powerful enough to actually get that down. The variability is brought down in spite of what they're doing. They're doing all things wrong, but still you're getting it better. And that's basically what it is. Here, you're talking about juice, sathukudi juice. I told him a lot of times, look, my impression is you don't take it, you see it, you believe it, do what you want, it's up to you. Fine, so that's that. So anyway, so that's what happened here. This was pre-Igla Elixir, and this was post. You can see the variability coming down pretty well, pretty flat. And equally, his HbA1c got better sequentially, and after 6 months, his HbA1c dropped down to 6.5. So you can see the journey going very well in terms of proper control. So what are the practice points I have from those 2 cases? You have co-formulations which actually offer 24-hour basal control, and you have a prandial insulin which offers an appropriate prandial control. You also have co-formulations with basically a long-acting basal insulin and a GLP-1. And this would actually result in appropriate control in terms of glycemia and in preventing glycemic variability and hyperglycemia. So co-formulations add to the synergism, and that was what I was talking about. It takes 2 to tango. So if you look at what all we have, you have a variety of things. You have, the faster-acting insulins, the ultra-fast-acting insulins, what I call the Formula One insulins, really fast. And then you have inhaled insulins. My endocrine colleague must have spoken to you about this earlier. And then you have the CGM, AID systems. You have the inhaled insulins, which obviously, are again a newer addendum. Again, you use it at certain places. This Technosphere insulin, which is an oral inhaled insulin, basically is an added armamentarium as to what you can do. Now, after all of this, if I were to tell you, today is Sunday, you're going back on Monday to your clinical practice, 5 things to do on Monday morning. If you were to take this from my presentation, the new tricks you would learn from this talk. First, upgrade yourself in terms of insulin. Upgrade yourself in terms of what would be an appropriate insulin. Maybe you may need to give an analog basal or an analog prandial. Clearly, that is a little bit more expensive, but however, if you use that, the dose would come down. So before intensifying, treat with analogs. Combine intelligently. So you could combine with the GLP-1 and basal insulin. Prepare patients for a long-acting journey. So a once weekly, maybe it may be effective, but a once weekly GLP-1. Prescribe lifestyle, prescribe diet, and prescribe CGM and self-monitoring, because seeing is believing. And remember, there are automated insulin deliveries, and this technology is no longer for type 1. I'd like to end this with this. Now, people drink. Now, I'm a teetotaler, disclaimer. alcohol is dangerous to health. But people like a drink in different ways. Some say I want it on the rocks, some say I want it with soda, some say I want it with water, some say I want it neat. Now insulin is like that. Everyone has a different need. Your drink comes in a fixed ratio of water, soda, and ice. You're unable to titrate to optimal terms. Your patient also comes in different colors. You'll need to titrate accordingly. So in 2026, we're discovering new ways for insulin to work. Smarter, deliver better, and combine more powerfully. Thank you very much for the opportunity.